Imagine a sudden, severe, electric shock-like pain hitting your face just because you smiled, brushed your teeth, or felt a light breeze. Today we are exploring the electrical atlas of a condition known as trigeminal neuralgia, historically referred to as tic douloureux or Fothergill's disease.
Tic douloureux translates to painful jerking, which perfectly describes the sudden facial muscle spasms triggered by these paroxysmal pain attacks. To understand trigeminal neuralgia, we have to look at the anatomy of the fifth cranial nerve, which maps out into three distinct territories on the face.
V1. The upper area around the eyes and forehead, which is actually the least affected zone. V2. The middle area, which experiences a high frequency of pain. V3. The lower jaw area, which has the highest frequency of attacks and includes the motor innervation for chewing.
A crucial rule of this condition is laterality. It is virtually always unilateral, meaning it never crosses the midline of the face. Interestingly, there is a right side dominance because anatomically, the foramina, or openings that the nerve passes through, are smaller on the right side of the skull. So why does this happen? The presentation breaks it down perfectly into three components: the loop, the wire, and the spark.
The loop. In 75% of classical cases, the culprit is an aberrant vascular loop, most commonly the superior cerebellar artery, that physically compresses the nerve at the root entry zone. The wire. Because of the chronic pulsation from that artery against the nerve fibers experience severe demyelination, effectively stripping the insulation off the nerve wire. The spark. This leads to an exposed, hyperexcitable nerve. Innocuous, non-painful stimuli, like touching the face, can easily cross a pathologically lowered threshold, resulting in extreme, misfiring nerve impulses.
Not all trigeminal neuralgia looks exactly the same. It generally falls into two categories.
Type 1. Classic. Presents with sharp, stabbing, electric shock-like pain that lasts for seconds to minutes. It is strictly unilateral and triggered by innocuous touch. The mean age of onset is typically older, around 53 to 57 years old. Type 2. Atypical. This features constant aching or burning pain that is prolonged. It can sometimes be bilateral and is less reliant on specific triggers. It also usually presents in a younger demographic.
Speaking of demographics, the condition has a 3 to 2 female to male ratio. And there is a massive clinical red flag to watch for regarding multiple sclerosis. Patients with MS are 20 times more likely to develop trigeminal neuralgia, often presenting as secondary TN, which can be bilateral and appear at younger ages.
If you break down the anatomy of a type 1 attack, it follows a strict sequence. It starts with an innocuous stimulus, like washing your face or eating, hitting a specific trigger zone. This is immediately followed by the sudden, severe paroxysm of pain. Finally, the pain terminates abruptly into a refractory period where the patient is completely asymptomatic. Because of this intense cycle, doctors look for specific red flags during a clinical visit. The frozen face. Patients will present expressionless and speak minimally to avoid triggering a paroxysm. Weight loss and decay. Severe fear of pain leads to restricted eating and poor oral hygiene, resulting in visible weight loss and decaying teeth. Sleep preservation. Attacks almost never occur during sleep.
Diagnosis is primarily clinical, focusing on the paroxysmal nature of the pain and trigger zones. An MRI is highly recommended to screen for tumors or MS, and to spot those vascular loops. But doctors also use the carbamazepine test to confirm the diagnosis. A lack of pain remission after a 5-day trial of this drug heavily casts doubt that the patient actually has TN.
And here is a massive clinical trap. Traditional analgesics like paracetamol, NSAIDs, and opioids are virtually useless for type 1 paroxysmal pain. Instead, the first line of defense focuses on stabilizing the nerve wire. Carbamazepine and oxcarbazepine are the first-line champions, helping 90% of patients achieve initial pain control by stabilizing hyperexcitable sodium channels.
When medications fail or cause too many side effects, patients move up the management ladder to surgical options.
The gold standard is microvascular decompression, or MVD. This is an open surgery where the surgeon identifies that aberrant blood vessel and physically separates it from the trigeminal nerve using a tiny Teflon sponge buffer. It is highly effective, leaving 62% to 89% of patients totally pain-free at a 3 to 11-year follow-up. If a patient is unfit for open surgery, doctors can look at ablative alternatives like stereotactic radiosurgery, gamma knife, or balloon compression. The concept here is to intentionally damage the trigeminal nerve root to blunt the sensory transmission. However, the trade-off is a higher recurrence rate and a guaranteed degree of facial numbness.
Thank you for watching. If you found this video helpful, don't forget to like, share, and subscribe for more educational content.